Hi guys.
Hi.
Hi.
Is my voice clear?
Yeah, it is.
Okay, perfect. So I'm gonna share my screen and let me know like how the connection is and if it's working fine.
Okay.
Okay, so to share them. Okay, so can you see my screen?
Yeah, we can.
Yeah,
Okay, I'm gonna move forward. So can you guys see the animations?
yeah, we can.
Okay, perfect. Do you see the answers on this side or do you just see the slides? Do you see like my notes section?
Yes.
Yeah,
You can see the note section?
yeah, we
Yeah,
can
we
see it on the
can.
side.
Like this one? This part?
Yep.
Yeah,
Oh.
upper trunk, lower trunk.
Oh. Okay, wait, how do I fix that? So I was on presenter's view. Okay, what about now?
No, we can still see it.
You can still see it?
Yeah,
Can you see like these two windows or do you just see one window?
two windows.
Because look, they're like this is what they're telling me. It's saying that this is what my audience is seeing. So according to Canva, this is what the audience is seeing. They shouldn't be seeing my notes.
We can see both of them.
Mm, because I have things, so how can I present? Because I need the note section. So, okay, so Assalamu alaikum everyone. My name is Hiba Raheel. I'm a sixth-year medical student, and thank you so much for coming to the panel today. I'll be teaching you guys the clinical anatomy of the upper limbs and lower limbs, and in the process, I would try to like cover the basics as well. So, you guys are sort of revising the basic anatomy as well alongside. So if you have any questions, just stop me right away. This is not me, trying to like teach you and not listen to your questions. This is supposed to be an interactive session. Definitely stop me along the way, ask questions and answer my questions. I have some questions for you as well. And yeah, this presentation is not it's not a replacement of Dr. Atif's presentation, so don't use it as a substitute. Instead, use it alongside his presentation just to kind of like help you understand certain concepts better. And yeah, that being said, we will inshallah finish within the 2 hours. It won't take us that long. And yeah, we will have sufficient time for anything that you want me to go over or you want me to stop and answer. All right, so let's begin. First of all, these are our objectives. So first I'm going to be covering the peripheral nerves injuries, so the musculocutaneous nerve injury, axillary, radial, median, and ulnar nerves. Then we're going to be talking about some bony injuries, and then we'll move on to the questions. Um, okay, so let's like take a step back first and kind of like go over the brachial plexus, right? So I know that this is something that is quite like it's not difficult, but it's hard to remember. It's not difficult to understand, and I know that it took me a million times to kind of memorize it, and I can still say now, even in fifth year, I still don't know it. Like before your lecture, I actually had to go over the basics and like try to remember each nerve and like each pathway and stuff. So if you feel like, oh my God, my exam is on Sunday and I don't remember what the brachial plexus is, don't worry. Do not worry at all. The first tip I would give you is as soon as you go sit in the exam, just you have like a paper, right? You have a sheet of paper, draw the brachial plexus, right? So last thing you revise before going into the exam is the brachial plexus schematic diagram. First thing you do, just draw the brachial plexus on your paper and then just put it aside and then go on to solving the rest of the exam, and then you're good. Okay. So let's quickly revise the brachial plexus. So I have a mnemonic. I'm sorry it's not written on the slide. So if you can note it down somewhere. I'm pretty sure someone has already told you about it. It's called Read That Damn Cadaver Book. So what is the mnemonic stand for, right? So the mnemonic stands for the R in read stands for roots. So the brachial plexus essentially arises from the spinal cord, right? All the nerves in the body, they come out of the spinal cord. And so what region of the spinal cord, where does the spinal cord come out from? So as next to each vertebra. So your spinal cord is located inside the vertebra, which is the backbone, right? And so between the backbone, that is where your spinal cord is running. It's just like a jangled bunch of nerves. And so between every spinal bone, we have these nerves coming out on either sides. Okay, so let's first look at the brachial plexus, which is the area, which are the bunch of nerves that come out from your neck on both the sides, right? So they come out from C5, which is your fifth cervical bone, then the sixth, the seventh, C8, and then T1. So your first thoracic vertebra, okay? So next to these bones, you have these bunch of nerves coming out, right? So what are these nerves? We have the C5 nerve, which comes out from the C5 vertebra. Then we have the C6 nerve, C7, C8, T1. So these are your roots of the brachial plexus. This is kind of like, I want you to think of brachial plexus as like a tree, okay? So you have the roots of the tree, then you have the trunk, and then you have like the branches, and then at the end, like you have the leaves, right? So I want you to kind of think of the same analogy here. So you have the roots, C5, C6, C7, C8, T1. Then the roots go ahead and they give rise to the trunks. Okay, just like we have in a tree, we have the trunk, right? The roots, they form the big trunk. So similarly, we have the trunks and we have three trunks. We have the superior, the middle, and the inferior trunk. Okay? And then in a tree, from the trunk comes like these tiny, tiny branches, right? So in the brachial plexus, let's call it divisions, okay? So each trunk gives off two nerves, one anterior and one posterior. So these are the trunks and they all give off two nerves, one anterior, one posterior. So in total, since we have three trunks, we're going to have 6 divisions, 3 anterior and 3 posterior. All right, now what comes next in a tree? Next, we have further branches, right? So we're not towards the end yet. We're still not towards the leaf part. We're still in the wood. We're still in like the branches area. So next we have cords. So again, we have 3 cords, and now the brachial plexus, it has reached under the clavicle. So the brachial plexus sort of starts from the side of the neck, and then it goes below the clavicle. So it goes under the clavicle like this, and then it comes out, right? So the cords are the ones that go in coordination to, do you know what artery this is? You can say it in the chat. Anyone know what artery this is?
Axillary.
Excellent, very good. That's the axillary artery. Do you know what part of the axillary artery that is?
Second.
Excellent, very good. So that is the second part of the axillary artery, and so your cords sort of go in coordination to the second part of the axillary artery. And so once they go close to the axillary artery, we call them the lateral, the posterior, and the medial cord. So now let's take a look at this diagram right over here. So again, these were my roots, C5, C6, C7, C8, and T1, okay? And then we have, these are the trunks that we had, and then these were our divisions, and then lastly we have the cords, right? So sort of over here is where we're going to have the second part of the axillary artery. And so from here, we have these important peripheral nerves coming out, right? Now, here's where I want you guys to sort of answer my questions, okay? So let's go back here. So from the lateral cords, we have the peripheral nerves coming out. So we have the musculocutaneous nerve, your axillary nerve, your radial nerve, ulnar nerve, and then we have a very important nerve, the long thoracic nerve, but it doesn't come out from the it doesn't really come out from the branches. Instead, it comes out from the roots. So let's go here to this diagram, and I want you guys to help me label it, okay? So can anyone tell me what A is?
Dorsal scapular nerve.
A. So this is your C side root. And
Oh,
this is
okay.
your-
I think it's superior trunk.
Yeah,
Sorry,
excellent.
sorry. I think I said like the nerve that gets
The
out.
nerve. Yeah. Don't worry about it. So the nerve that you just actually mentioned, it's good that you mentioned it. So there are certain nerves in the brachial plexus that I'm not encouraging you skip, but I'm gonna say that they're not as important. Then there are nerves that you absolutely have to know, and those are the nerves that we're gonna talk about today, okay? But then there are some nerves that I would say that if you kind of like skip it, you're not in too much trouble. Okay, so that's all I'm gonna say. So yeah, you're correct. This A right here, it's your upper trunk. Okay, now what about B? So if this is the upper trunk, what would B be? Excellent. That's your inferior trunk. Very good. Okay, so that is that. And then remember we said that the okay, so I said that there's one nerve that comes out from the roots. I've mentioned this already, and you must have taken it. Do you know what that is? Perfect. Yes, that is your long thoracic nerve. Now, this nerve, it's very easy to remember because this is the only peripheral nerve that comes out from the roots and not the branches. There are several like nerves that you're going to see, but your long thoracic nerve is a nerve that you cannot miss. This nerve has a lot of clinical significance. Dr. Ahatta, who loves to bring these questions. I remember when I took MSK, we had an entire SAQ on just the long thoracic nerve. So this nerve is extremely important. Don't miss it, okay? Can anyone tell me what D is? So if you can see, let me like give you a little hint. D bifurcates into two nerves, and we're gonna get into that, but that's like a huge hint. What do you think D would be? Excellent, very good. D is your posterior cord. Now the two nerves that come out from it, do you know what those two nerves are?
Axillary
Excellent.
and radial.
Very good. Good job. Axillary and radial. So the posterior cord sort of comes out at the back, that's why it's called posterior. And so I want you to think that posterior cord has two nerves that come out from it, and they supply the back portion of your arm. Okay, so they immediately come out and they don't go to the front of your arm, they immediately go to the back of your arm, right? So those two nerves are called the radial nerve, which supplies the posterior compartment of your arm, and then it supplies the dorsum of your hand, and you have the axillary nerve, which supplies your deltoids, and it supplies your lateral arm, okay? So these are the two nerves that come out immediately. Right, so there's one nerve. Okay, now the next three peripheral nerves that we have, which is the musculocutaneous, the median, and the ulnar, they're also really easy to identify. So I want someone to tell me what I would be. Oops, sorry, let me go back. Okay, does anyone know what I is? Yeah, go ahead. Okay, so everyone who said in the chat that it's the ulnar nerve, you're correct. This is your ulnar nerve, and this is the nerve that, if you see, comes straight out of your lower trunk. So you can see like it goes right straight, and so it's very easy to identify. This will run towards the medial side of your arm. It will go below the funny bone, which is your medial epicondyle, and then it would supply like your ulna, which is like your ulnar side of the hand, and it will supply the hypothenar, so your muscles below the pinky. Okay, so this is your ulnar nerve. Then we have, as the name suggests, median nerve. So which one of them would be your median nerve? Excellent. Very good. This is your median nerve. And right, someone said very correctly that your musculocutaneous nerve and the ulnar nerve, they give off like one branches. It's not the musculocutaneous and the ulnar. It's actually your upper trunk and lower trunk that's sort of like continuing forward. And then they give off one branch, which forms the median nerve. Okay. And as the name suggests, it's median. It literally runs right through the middle of your arm, and it goes through your cubital fossa, which is over here. It goes through it, and then it supplies your muscles of the forearm. Okay. What about G, the last one that we're left with? Anyone know what G is? Excellent. Very good. That's your musculocutaneous nerve. And this nerve is the one that sort of runs laterally, and it supplies, it goes under the lateral epicondyle, and then it supplies the muscles in the arm and the forearm. One of the major muscles that it supplies is your bicep muscle. All right, so with that being said, this was an image that I think was in your lecture given by Dr. Atif, and this is very, I think it's an important image. It shows basically all the dermatomes. If you can't remember it this way, then I have like individual dermatomes in the upcoming slide. So let's hope that that would help you remember the dermatomes. Okay, so let's dive into the injuries, right? So the first injury that we're going to talk about is the musculocutaneous nerve. Okay, so musculocutaneous nerve, it comes out from C5 to C7. So C5, C6, C7. So these are the root values. So please remember the root values for each nerve. It's so very important. Okay. Now, what are the ways you can damage the musculocutaneous nerve? You can actually damage it in trauma. So anytime someone gets, like, for example, they get like cut here, or they get hit here, musculocutaneous nerve is something that you can damage very easily. Another way that you can damage it is through upper trunk compression, which is also called Erb's palsy. So does anyone remember what Erb's palsy is? Like, just describe Erb's palsy to me.
When the C6 and the C5 is getting cut because we are falling in outstretched,
Very
and
good.
so we adduct our hand and medially rotate it and pronate it.
Right. And so do you remember what this position is called? Like medially.
Waiter's tip.
Very good. Excellent. Good job. So musculocutaneous nerve is very commonly damaged in Erb's palsy, right? So here's a tip. In the exam, let's say you don't remember the mechanism of action, the mechanism of injury for these nerves, your safest option to go with is trauma. That's it. Simple. You don't remember, that's it. You get 1 point immediately. Trauma is something that you can just write for pretty much everything. And then so I'll take your question in just a second. Let me just finish the slide and then I'll take your question. Okay, now what are the sensory areas that the musculocutaneous nerve supplies? So the musculocutaneous nerve actually supplies this side of your arm, right? And it goes all the way to the base of your thumb, and then it supplies this side of your arm as well. So if you have damage to the musculocutaneous nerve, you would essentially lose sensation on the lateral aspect of your arm, which is basically the radial aspect. So this is the radial aspect, right? Your thumb is the radius, and this part of your arm or your hand is the ulnar aspect. So you're going to lose sensation on this side of the hand or the arm until the base of the thumb. So it goes all the way from the elbow to the base of your thumb. Okay. Okay. Did you get your? Okay. All right. Let's go to the next slide. Right, so let's talk about the motor deficits. So for the motor deficits for musculocutaneous nerve injury, I have divided it into the muscles that this nerve supplies, right? So there are 3 important muscles that are so important to remember for musculocutaneous nerve. Like, you can't go into the exam without remembering them. Your biceps brachii, your brachialis, and your coracobrachialis. Now, these 3 muscles are literally they are responsible for your entire upper arm movement. Okay, so let's talk about the brachialis and the coracobrachialis. So I'm not really going into like each and every function of the nerve, because this is something that you should have covered in the basic anatomy part, but hopefully if I talk about the clinical aspect, you will be able to remember a little bit of the basics, okay? So your brachialis and your coracobrachialis are two important elbow flexors, right? So if they are damaged, or like if the nerve supplying them is damaged, these muscles essentially become paralyzed, right? And so the patient will have weak flexion. Now, here's something very important to remember, that because the hand, the arm, the leg, and the lower leg compartment, the thigh and the leg compartment, they're full of muscles. A lot of the muscles in this compartment are sort of working together. And so another word for them is synergists, right? So they sort of work together. And if one muscle is damaged, subhanAllah, the other muscle covers up for it. And so the patient is not essentially completely paralyzed. They have an impairment of the function. There's a very big difference. Absence is when there's absolutely no movement. Impairment is when there is some movement, but the other muscle is sort of covering up for it. So I really want you to know this, that this is just subhanAllah, like how our body is made. Damage to musculocutaneous nerve is absolutely not going to make the person paralyzed. So do not write paralysis of paralysis of the muscle makes sense, okay? But don't say absent elbow flexion, because there are other muscles that will cover up for it. All right, now bicep brachii, your bicep is the major supinator of your arm. Like that's the major supinator. There are other supinators in the arm, which I'm really not going to go into, but I'm pretty sure you guys know those more than I do. So the other supinators, they will sort of cover up for bicep. And if the bicep is paralyzed, here the word paralyzed is correctly used, then there would be an impairment of supination, okay? And an excellent way to test for musculocutaneous nerve injuries. So if you noticed in pro, if you've had the pro session, they have this reflex hammer, right? And so essentially the whole concept of the reflex hammer is to check for these reflexes. So since your bicep muscle is mainly supplied by the musculocutaneous nerve, when you strike the bicep tendon here, which is right below, like right above your elbow, if you strike it, the reflex would be reduced. Your arm would not move the same way, okay? And that is what you can write in the exam. So let's say if it comes in the exam, what would be the motor deficits of the musculocutaneous nerve, then you can say impaired elbow flexion, impaired supination, and absent bicep reflex. Simple as that. Divide it in your head in three categories. Okay. All right, axillary nerve. Now, axillary nerve is again a very important nerve that is damaged, and I would say that this is most commonly the one. Oh, what about loss of sensation? Okay, so I discussed the loss of sensation in the previous slide. Let me go back. Right, so loss of sensation would be anywhere below your thumb, so radial side, above and all the way till your elbow. So this is like the front of the arm, and then at the back as well. It covers like a little portion at the back. So remember that the musculocutaneous nerve does not supply the hand. The hand is mainly supplied by median and ulnar nerve, and then a little portion on the back side of your hand, like particularly this region, is supplied by the radial nerve, okay? So musculocutaneous nerve, you usually do not test the injury of musculocutaneous nerve through the sensory loss. It's preferable to check for injury through bicep reflexes, okay? I hope that answers your question. All right, now axillary nerve. So axillary nerve is again a very, very important nerve. It's something that you most commonly see in the clinics, and the reason why is because of its location. So the axillary nerve runs very close to the humerus, right? So any humeral damage, so like the humerus is the biggest bone, not the biggest, but like it's the long bone in your arm. And so if that gets damaged or fractured, axillary nerve can easily be fractured, okay? So what are the root values for axillary nerve? We have C5 and C6, All right. So, and how do they commonly get injured? The axillary nerve. So, like I mentioned, shoulder damage. So, any damage to the shoulder, the humerus, anterior shoulder dislocation, specifically anterior dislocation. Very, very, very important. Okay, not posterior, not inferior. Anterior dislocation. Why? Because the axillary nerve sort of just wraps around your humerus. So any push to the humerus from any push that would make the humerus go anterior and be dislocated from the glenoid cavity is most probably going to stretch your axillary nerve. And then we have fracture to the surgical neck of the humerus, because like I said, it wraps around the surgical neck of the humerus, or any compression. So usually breast cancer, very common site of metastasis of breast cancer is the axilla. And this is where your axillary nerve is there, right? That's where it's present. So any metastasis to the axilla, we don't only have breast cancer metastasis, but also we have lymph nodes. So we have, let's say, the cancer of the lymph nodes. If they get enlarged and big, they can compress on your axillary nerve. Now, what are the sensory deficits? So your axillary nerve essentially just supplies this area, the upper region of your arm. It supplies not only the deltoid muscle, but like the skin around the deltoid muscle, right? So that definitely would be damaged. The senses would be reduced over there. Another important thing that you can catch in the question would say the patient had obvious shoulder deformity or obvious loss of contour of the shoulder. So what does that mean? The contour of the shoulder that we get is usually because of the deltoid muscle, right? So if the axillary nerve, which is supplying the deltoid muscle, is damaged, then you can understand that the deltoid muscle is not working. Now, if the deltoid muscle does not work, it starts to lose its mass. So it sort of starts to lose its shape and become like shriveled and starts to like, in a way, die. And when it loses its shape, the shoulders would appear flat. So let me see if I have a picture. I think I have a picture in the upcoming slides. What about loss of sensation, neck of humerus fracture, Erb's palsy? No, Erb's palsy, yeah, I think it would cause actually, yes, you're right, because it's off the upper trunk, so it could cause, yeah, axillary nerve damage. I have a question. How could you check the biceps from the back? Isn't it the triceps? What do you mean? Oh, you were talking about, the reflex? Right. So for the reflex, you put your arm like this. Yeah, I get what you mean. You put the arm here, and the tendon that you're striking sort of like attaches. You're right, it attaches here. So you can't really strike the person here because they have like important nerves and like muscles, nerves and arteries here. So you sort of like place their arm in like this way, and then you strike it, and then if the arm jerks like this, that's your bicep reflex, okay? And yeah, you're right. That's the tricep. The tricep is here. You corrected me. Thank you. The tricep is here, and the bicep tendon is here. Okay. But to check it is very similar. You don't really need to know for the exam how to check it. You just need to know that it's going to be impaired. Okay. All right, so axillary nerve, I have divided it again to make it easier for you, like how to remember in the exam. I have given you two muscles, very important muscles that are supplied by the axillary nerve. And so any impairment, any reduced nerve supply to these muscles is essentially going to lead to certain motor deficits, right? So what are the motor deficits? We have the deltoid muscle, which is one of the biggest muscles in your upper arm region, and that is supplied by your axillary nerve. So deltoid, can anyone tell me what is the range of movement? First of all, what is the movement that the deltoid does, and what is the range of movement of the deltoid muscle? Very good, excellent, very good, exactly. So it does 15 to 100 or like 120, and then 120 and above. Do you know what muscle does 120 and above? So 120.
The trapezium.
Excellent, very good, trapezius. And what initiates abduction? So from 0 to 15 degrees. Very good. Yeah, go ahead.
I wanted to say supraspinatus, but someone said it.
Yeah, it's fine, no worries. You're correct. All of you guys are correct. So the supraspinatus muscle initiates the abduction, and then the deltoid muscle takes your arm from 15 degrees to 120 degrees. And then from 120 degrees to 180, that is the responsibility of your trapezius muscle. So again, you can understand that abduction would not be absent in axillary nerve injury. Instead, it would be impaired. It would be reduced. The patient will not be able to take their arm from 15 degrees to 120. So the patient is commonly going to say in the question, you'll see that the patient is going to say that I can lift, the patient is going to say, I can lift my arm, I can abduct, however, I need to take my other arm and move my arm above. When they say that, I want you to immediately think of axillary nerve injury, okay? Another very important muscle, I mean, it's not very important, but it is important, is the teres minor. So teres minor is responsible for external rotation. So it is responsible, again, it's not the only muscle that is responsible. So external rotation of the arm would be impaired. There would be other muscles doing external rotation. But if there is anything that I want you to remember is the deltoid muscle. Deltoid muscle would be, there's only one supply that deltoid has, which is your axillary nerve, right? And if you know that the deltoid muscle is actually made up of 3 like differently oriented fibers. So if the deltoid muscle gets impaired, then you can imagine that there's a lot of functions that would be lost. We will get to the painful arc syndrome, and it's not because of either. It's actually because of something else, the third muscle. It's because of the supraspinatus muscle. It's called supraspinatus tendinitis. We'll get to that shortly. All right, let's move ahead to the radial nerve injury. All right, so the radial nerve injury is actually something that was very talked about a lot in depth, and so I have more slides on the radial nerve injury, and so I want you to sort of follow along. Again, it's one of the important nerves that are injured and very commonly injured because of the way it travels in the arm. So remember, since axillary and radial nerve kind of they come from the posterior division, correct? So when they come from the posterior cords and the posterior divisions, they sort of are the deepest as compared to other nerves like musculocutaneous, median, and ulnar nerve, which kind of like are superficial. So for the radial and the axillary nerve, if you connect the dots, damage to the humerus is definitely going to damage the axillary and the radial nerve. Think about it. Have you ever heard of any other nerve being damaged because of damage to humerus? No, it's always usually either axillary or radial, okay? So radial nerve goes from C5 to T1. So it comes out from like all the roots, and it makes sense because all the roots, they give off a posterior division, right? And then they join together to give off your radial nerve. Okay, so how can the radial nerve be damaged? So number one, it can get damaged in the axilla. So there are 3 common places where the radial nerve can be damaged. So your axilla, the mid-arm, and the wrist. So because the radial nerve goes all the way from here and all the way down here, so along its course, it can be easily damaged, right? So let's talk about the axilla. So in the axilla, usually when someone breaks their leg or their foot, in order to help them walk and move, we give them crutches, right? So if you give them axillary crutches, they put a lot of pressure in their axilla to support themselves onto the crutches. And in this case, prolonged use of crutches can actually compress the radial nerve in the axilla. Another way that the radial nerve can be damaged within the axilla is through Saturday night palsy. Now, does anyone know or remember what the Saturday night palsy is? Anyone? Excellent, very good. So Saturday night palsy is actually a very easy thing to remember. So it's actually the origin is very funny. So when people go out in the West, they go out on Friday night, they get like drunk or whatever, and they come back home and then they just slouch over the chair, they pass out over the chair with their armpit kind of like hanging over the chair this way. And then in that case, the axilla gets compressed. So the axilla gets compressed. It's called the Saturday night palsy because it leads to a series of motor and sensory deficits, and it leads to compression of certain nerves. And one of the nerves that are damaged in this process is your radial nerve, okay? Now let's move a little lower, okay? Let's go from the axilla to the middle of your arm. So in the middle of the arm, the radial nerve wraps around the humerus. When it wraps around the humerus, any damage to the mid shaft, so essentially the radial nerve goes straight and then it goes around the humerus and then it runs in the posterior compartment of your arm. So any damage, any fracture along the mid shaft of the humerus can cut the radial nerve. And lastly, the wrist. So radial fracture, so the radial bone, if it gets fractured, it can damage the radial nerve. Wearing tight bracelets or handcuffs or repeated pronation and supination, like for example, the screwing movement, it can definitely damage the radial nerve. I remember, I think it was our batch, or was it the batch before us? I think it was either of them, but we had a question in which there was this a worker, yeah, it was a worker, a mechanic or something, and his job was to screw light bulbs and like to screw the hammer and stuff, and like there was like this long question description of his symptoms and whatnot, and then the answer, one of the questions was which of the nerves would be most likely damaged in this case, and the answer was radial nerve, but nobody really thought about it because, you know, we were like, yeah, radial nerve, we were always thinking of mid-shaft fracture or Saturday night palsy, but nobody really thought that the radial nerve can actually be damaged in the wrist. So I don't know if like Dr. Atif still mentions this question, but he loved that question. He bought it, and I think a lot of people got it wrong. So these are like the following ways that the radial nerve can get damaged. So it's very important to remember over here that the higher the radial nerve is damaged, the more pronounced the motor deficits. Because imagine if you're cutting radial nerve off at the very, like the source, like in the axilla, then not only does the tricep and the arm muscles get paralyzed, then also the forearm muscles get paralyzed, and then the hand muscles, and like all these muscles are paralyzed, right, that are supplied by the radial nerve. If the radial nerve is sort of damaged in the midshaft region and the branch to the tricep has already been given off, then the branches that come after that are damaged, and so the tricep function is preserved. And lastly, if the radial nerve is damaged in the wrist region, then everything else in the arm would be preserved, and the only damage, or like the only motor deficit that we would have, would be in the hand region, right? So the higher the damage, let's say, the more dangerous it is, okay? Or the harder it is to deal with the patient. Okay, now the sensory deficits, so the major nerve supply of the posterior hand, so like not just the hand, but also the forearm, and then the back of the arm is your radial nerve. So as you can see in this image, it covers a very significant portion of your hand, and then the forearm, and then the shoulder region. So sensory deficits in any, so damaged radial nerve can cause a sensory deficit in the following regions. A very good way to test clinically for radial nerve is you just press this region of the patient's hand. So you see this region, just press it, and if the patient feels the pain, then that means their radial nerve is intact. If they don't feel the pain over here, that means their radial nerve is most likely damaged. All right, so radial tunnel syndrome. So this was something that was mentioned in your lecture. So radial tunnel syndrome is basically, like I said, in the exam, the best way to answer the questions about most common mechanism of injury to the nerve. The best way to answer it, there are two answers that you can give, and I'm pretty sure he's going to give you the mark. Trauma and entrapment, or nerve impingement, or nerve entrapment. These two answers unless the question is like 4 marks, then okay, he may only give you 2 marks. But usually these kind of questions are only 2 marks. So if it's 2 marks and you say these 2 things, you're gonna get the answer. Okay, so like remember these 2 causes very, 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 very well. Okay, so radial tunnel syndrome is basically when the radial nerve gets entrapped at the elbow. Okay, so don't confuse this with the carpal tunnel syndrome, because the carpal tunnel syndrome occurs on this region of your hand and it occurs at the wrist. However, this occurs a little high above at the elbow region. And what really happens is that there are certain structures in the elbow, like such as some ligaments, some fibrous bands, some tendons, because there are a lot of tendons in the elbow region. They compress the radial nerve against certain structures. So what can happen is that below the elbow, you will have radial nerve injury, okay? And so this does not cause wrist drop. Please do not confuse this with wrist drop. This is not wrist drop, okay? And the result, like as a result, because the radial nerve is being compressed in the elbow, it can cause loss of extension of the wrist and obviously the fingers, right? And you would have pain over the extensor aspect of the forearm because the nerve is being compressed. The patient would be in pain. So these are the signs. So let's go over the signs of radial tunnel syndrome one more time. Number 1, the patient is going to complain of pain on the back portion of his hand or arm. Next, they're going to say, "Doctor, I'm not able to extend my wrist and my fingers." When they say that, think of radial tunnel syndrome. All right, so radial nerve injury. So I'll go over this. Like this is like a recap that I have of what I said so far. So if radial nerve is damaged in the axilla, this is like the worst kind of damage to the radial nerve that you can have, because everything below the axilla, everything in your forearm to your arm to your forearm to your wrist and hands, everything is going to be damaged. Okay. So if the radial nerve is damaged in the axilla, you can have impaired forearm extension because your tricep would be paralyzed, and it's going to be impaired because it's not going to be completely absent. It's going to be impaired, and as a result, it's going to cause wrist drop. So again, let's take a few steps back, okay? Wrist drop occurs when the radial nerve is damaged in the axilla. Radial tunnel syndrome occurs when the radial nerve is damaged within the elbow. So again, if the radial nerve is damaged in the mid-arm or the axilla, you will have wrist drop, okay? So kind of think of it this way: high above, wrist drop; a little below, radial tunnel syndrome, okay? And if it gets damaged in the wrist, the patient would be able to extend their arm. They will be able to have all the functions of the arm. The only thing that they won't be able to do is form a grip. Okay? Can I please repeat? Okay, I'll repeat, of course. All right, so this slide, you want me to repeat this slide in particular? Do you want me to repeat the slide? Okay, the axilla would cause herb Duchenne palsy. What do you mean the axilla would cause? Yeah, so you know the mechanism of action of herb Duchenne palsy, the radial nerve can be damaged within that because the radial nerve comes out from the superior trunk. So yeah, but that's not what I mean. In the axilla, if the radial nerve is damaged in the axilla or mid-arm, you'll have wrist drop, okay? You'll have wrist drop because everything else is damaged. Everything. You'll have the flexors that are damaged. You'll have the extensors that are damaged. Sorry, you'll have the extensors of the elbows that are damaged. You'll have the extensors in the posterior compartment that are damaged. Everything is going to be damaged, and as a result, the patient is going to have wrist drop. If the nerve is compressed in the elbow, so here in the lateral side of the elbow, in that case, you'll have radial tunnel syndrome, okay? That is different from wrist drop. Okay, so I hope I clarified your question. Is it clear? Do you want me to repeat anything else? Anyone, do you guys want me to repeat anything, or do you want me to go over something? We have a bunch of questions coming up. So If you want, I can go back or we can move forward. Okay, so I think everything is clear. Stop me right away and I'd be more than happy to repeat anything. Okay, so I found this really nice table from Ambos. So this table is just sort of to like help you realize that the importance that I don't want you guys to first of all memorize this table. Okay, do not memorize this table. Please, please do not memorize this table. This table is just there to help you understand the importance of the radial nerve injury at different location of the arm. So one more time, if the damage is at the axilla, everything below the axilla would have sensory damage, right? And everything below the axilla would have motor damage as well. Paralysis of the triceps, paralysis of every single thing. Let's say that the damage is at the mid-arm, okay? There's like a mid-shaft humeral fracture. So everything below the mid-shaft would be paralyzed, right? And that's a very good way to help you understand where the nerve is actually damaged. So if you touch the patient here, they can't feel it, you know for a fact that definitely the damage is at the axilla, right? And if the patient can feel here, but they can't feel here at the back of the arm, then you can think that, okay, maybe the damage is in the mid-shaft of the humerus, okay? And again, the patient is going to have sensory loss. So what are the examples of sensory loss? Numbness, absence of sensation, pain. Similarly with motor functions, everything below the mid-arm would be paralyzed. The patient would have wrist drop. So they'll have weak or paralysis, weakness or paralysis of the hand and the extensors of the fingers. The patient will not be able to extend their hand at the wrist joint. If the radial nerve is compressed in the elbow, so if they have radial tunnel syndrome, in this case, they will have pain and tenderness in this part of the arm, and they will also have weakness of the extensors of the hand and the supinators. But extension at the elbow would be fine. Why? Because the nerve has already given off its branches in the mid-arm. It has still not given off branches supplying the muscles of the forearm. Clear? And then in the hand, it's different. Then it gets divided into deep and superficial, so no need to know this. But like till here, it's very important, okay? I hope that's clear. Any questions, you guys? Anything that you don't understand so far? Okay, so let's move on to the median nerve. So the median nerve, as I mentioned previously, the median nerve travels in the middle of your arm and it goes underneath the it goes underneath the cubital fossa, the antecubital fossa here. And the median nerve comes from C5 to T1. Again, there are different areas where the median nerve can be damaged. Same goes with every single nerve. The higher up the damage, the worse the symptoms. The lower down the net damage, the better the symptoms. Like they're not going to be so bad. So if it's, for example, high up on the arm, how can it get fractured? So it can definitely get fractured through the supracondylar fracture because, the supracondyles make up the floor of the cubital fossa, right? Your elbow is what makes up the floor of the cubital fossa. So if there is fracture of the elbow or the supracondyles, then it can lead to proximal damage of the median nerve, okay? So the proximal damage is not in the arm, it's actually in the forearm. And then distal, so it would be like, let's say, in the hand. So one of the very important ways that you can damage your median nerve is through carpal tunnel syndrome. Now, who can tell me what carpal tunnel syndrome is?
The building up of fluids in the reticulum of the hand and the compression of the median nerve because of these fluids.
Yeah, very good. So it's not actually buildup of the fluid. It's basically because of constant pressure or constant compression, the retinaculum kind of becomes inflamed. And when there's inflammation, then there is fluid, like obviously every inflammation in the body is followed by fluid generation. So it's not really it's not really fluid, it's just that constant like friction and constant rubbing and compression of this region of the hand can lead to carpal tunnel, okay? Another way is through wrist laceration or suicide attempt. When they cut the wrist, then it could lead to median nerve damage. Median nerve damage. The median nerve can also be compressed between the humeral and the ulnar heads, okay, of the pronator teres. So going back to basics, pronator teres has two heads, correct? It has the humerus head and it has the ulnar head. And when the median nerve gets compressed between these two heads, it can also lead to injury. So again, you know, if you guys notice, every single thing can be either wrapped up, every injury of the peripheral nerve can be either wrapped up under trauma or compression, trauma or compression, trauma or compression. If you say this in the exam, you're good to go. If you remember trauma, like for example, median nerve, you remember carpal tunnel syndrome, axillary nerve, you remember Erb's palsy, these are very basics, then you're very good. You're good to go, okay? Now, median nerve, I would say that it has the most important sensory supply in the entire body, okay? In the hand region or the arm region. So the sensory deficits of median nerve depends on, again, where the injury is. If it's like proximal, so like close to the elbow, then everything from the elbow below that the median nerve is supplying there's going to be sensory loss. If it's distal, so like if it's like here, then again, it's very similar to the proximal side as well, okay? The proximal injury. So let me further elaborate that. Proximal injury, if there is injury to the median nerve proximally, you will have sensory deficits over the thenar eminence, so like below your thumb, the palmar aspect, and the index, the middle finger, and then the lateral side of your ring finger. So lateral side of your ring finger, okay? Distal injury is kind of the same way, because if you remember over here, the median nerve does not really give sensory supply. The sensory supply of median nerve is limited to your hands, right? So one more time, if there is damage to the median nerve, then the sensory loss would be essentially in the hands. Where in the hands in particular? The palm, the base of the thumb, the side of the thumb, the first finger, the second finger, and then the lateral aspect of the ring finger. Okay. Will a recurrent branch of the median nerve get damaged in the carpal tunnel syndrome? I'm not really sure. But I think that the recurrent branch does, isn't it the one that goes below the carpal tunnel? Yeah, it goes underneath the carpal tunnel, and then there's one branch that goes above. So yes, it's this one, the one that we're talking about is the one that will go within the carpal tunnel, and that is the one that is going to get damaged in carpal tunnel syndrome and cause the sensory deficits. The one that goes above, it's not going to get damaged in carpal tunnel syndrome. Okay, so what about the motor deficit? So one of the most important muscles that the median nerve supplies is your thumb. So your thumb is the most important finger from all the fingers, right? Like there is a whole type of surgery for just the surgery of thumb. It's called plastic surgery. And if there is like any damage of the nerve which supplies these fingers, okay, khalas, they don't care that much about it because one finger can compensate for the other, but there's no finger that compensates for the function of your thumb. So if the median nerve, the motor branch of the median nerve gets damaged and that branch supplies the thenar muscles, it's going to lead to atrophy of the thenar muscles. So every time a motor branch of a nerve gets damaged or stops working or anything, it can cause paralysis of the muscle. And so when you don't use that muscle will undergo atrophy and it will lose its shape, it will lose its contour. And so you can actually see patients with median nerve motor injury, this part of their thumb, it would be like shriveled and would be really shrunken. In addition to that, it also supplies the flexors of the wrist and the thumb, the index finger, and the middle finger. So the flexion of the fingers would be damaged. You'll have proximal injury as well. So above the anterior interosseous origin nerve. So if it's like proximal injury, which I mean by the supracondylar fracture of the humerus, it's going to lead to hand of benediction when making a fist. Okay. Yes, the thenar muscles are the ones that are under your thumb over here, and then the hypothenar are the ones that are under your pinky. All right, so one of the last peripheral nerves that we're going to talk about is the ulnar nerve injury. So the ulnar nerve is a nerve that runs towards the lateral side of your arm, right? Sorry, the medial side of your arm. It goes beneath the medial epicondyle, also known as the funny bone, and then it emerges, and then it supplies your hypothenar eminence, and it supplies the skin beneath the pinky and like behind. Okay. So what is the root value? The root value is C8 to T1. If anything that you guys would want to remember for the exam, it's the root values. Root values are really important. He will definitely bring this. It could come as an OSCE. It could come as even an SEQ or an MCQ station. Honestly, this is one of the questions that can come in any exam, like any type of exam. So let's look at both injuries to ulnar nerve proximally and distally. So the proximal injury, like I said, it comes from underneath the elbow, correct? So any damage to the medial epicondyle or the funny bone, like any fracture when you bang your middle side of your elbow really hard against something, and it can cause a fracture that can definitely damage the ulnar nerve. Similar to the radial nerve, the ulnar nerve can also become entrapped over here beneath the medial compartment of the medial epicondyle, just like the radial tunnel syndrome, except we don't have an ulnar tunnel syndrome. It's not really called that. But yeah, again, it can become entrapped. So see, trauma, fracture, and entrapment. So distally, the ulnar nerve goes very close to the hamate. So the hook of the hamate is one of the carpal bones, right? So the hamate actually has this sort of like a protrusion, and it's called the hook of the hamate. And that is something that is very commonly fractured, especially when someone falls on an outstretched hand. The hook of the hamate is something that is very commonly damaged and fractured, sorry. And any fracture to hamate can lead to ulnar nerve injury. So ulnar nerve supply, very easy. Remember, it supplies the ulnar side of your hand. So it supplies your pinky, and then the half of the ring finger supplies this part of the palm, and as well as the back, okay? It basically supplies the hypothenar eminence, or the hypothenar region.
It also supplies the adductor transverse and oblique.
Exactly, it does, yeah. But those are the motor, right? We're talking about the sensory supply right now. We're coming to the motor supply in a minute. Yes, obviously it also supplies the interossi and the two medial lumbricals. So, the patient would not be able to do abduction and abduction of the hand. So they won't be able to do these two fingers. But we were talking about the ulnar supply. So one of the major muscles that the ulnar nerve supplies is the hypothenar, right? So the skin above the hypothenar is going to definitely be would lose its sensory supply. So any damage to the muscles, any damage to the motor branch of the ulnar nerve, which supplies the muscles, would lead to something called the ulnar claw. Just like we have the hand of benediction, we have the ulnar claw. So what is the difference? Let's go back to the median nerve injury. So I want you to take a look at this hand. This is called the hand of benediction. So your thumb and your first finger and the second finger would be basically the index finger and the middle finger. They're going to be paralyzed, and so they would be staying like this. The patient would only be able to move these two fingers. The ulnar nerve claw, or the ulnar claw, is exactly the opposite. So the thumb, the index finger, and the ring finger would be fine, but their pinky and ring finger would be paralyzed, right? They won't be able to move these. And so they will go like this, okay? It's exactly the opposite, the ulnar nerve and the ulnar claw and the hand of benediction, okay? Right, so proximal injury, if the injury is towards the elbow, then it can cause radial deviation because in the hand, just like in the arm, the biceps and the triceps are antagonists, right? They antagonize each other. They do opposite function. And so for that reason, your arm stays straight. Right now, it's straight. But if one of them was damaged, let's say the tricep would be damaged, then it would lose its contraction and bicep would be contracting. So the arm would be sort of flexed. Similarly, opposite, let's go to the opposite side of the spectrum. If the bicep would be damaged, but the tricep is working fine, in that case, there's nothing opposing the function of the bicep. So the tricep is going to be working extra hard. When the tricep works extra hard, the hand would be moved backwards. So I'm just giving you an example, okay? Similarly, let's go to the forearm. Let's say the extensors are not being opposed. So there's nothing opposing the extensors. Your flexors have stopped working in the hand. What would happen? Your hand would be extended because there are no flexors. Now, let's say that the flexors were damaged and let's say that the extensors were damaged and there is nothing to oppose the flexion. In this case, the hand would be extended, okay? So this is how it works with every antagonistic pair, every pair of muscles that antagonize each other. So when the extensors are damaged because the ulnar nerve is damaged, in this case, the radial, the hand would be deviating towards the flexors, okay? So it would be deviating towards the radial side. All right, I hope that's clear. And similarly, because the flexors are not damaged, the flexors are damaged, so there would be inability to flex the fingers and the little finger in particular. There would be impairment of flexion of the wrist and the medial fingers, impairment of like someone said, intrasi would be damaged, lumbricals would be damaged, so adduction of the fingers would be damaged. Lumbricals are damaged, so the little finger and the ring finger actions would also be impaired. Okay. The opposing motion would be overpronounced. Excellent, very good. Yeah, that's an excellent way to put it. So the opposing function would be overpronounced because there is nothing antagonizing it. Okay. All right, let's move on to questions. Okay, so let's move on to the questions. I want one person to unmute their mic and read the question and then attempt at solving it. Anyone, come on. It's okay. We're here to make mistakes.
Okay, I'll do it.
Yeah, go ahead.
24-year-old man is brought to the emergency room after he was involved in a motor vehicle accident. He complains of pain in his right shoulder. Physical examination shows bruising and tenderness in palpation just below the right cricoid process. He is unable to flex the right elbow or supinate the right forearm against resistance. There is decreased sensation to light touch over the anterolateral forearm. Which of the following labels structures of the brachial plexus is most likely to be injured?
Okay, so before you move on to giving me the answer, tell me what is important in this sentence. What stands out in this question?
I think he cannot flex the right elbow or supinate it, and also the sensation, the lateral part.
What muscle? Excellent, very good. So what muscle are we talking about here?
We're talking about the biceps brachii and the brachialis, I think.
Very good.
And we're also talking about the musculocutaneous.
Excellent, good job. So we are talking about the muscles that are supplied by the musculocutaneous nerve. So you have it that much. Excellent. Now locate the musculocutaneous nerve on the diagram above.
It's at G.
Excellent, good job. So the answer is G, very good. You did a very good job. So these questions are from AMBOSS, right? Now AMBOSS is obviously a very difficult source, and for year one, honestly, if you get AMBOSS questions wrong, it is completely fine. That is okay, because they're very hard. They're very, very hard, and I completely understand if you get them wrong. But however, if you get them right, then that is a really good sign. That means, you know, you're doing great, you're learning great, and you've done something right. Okay, so don't worry if you get them wrong. I will give you some extra resources at the end of the lecture, at the end of the session, that you can definitely use to practice more questions. Okay. Who would like to attempt this aside from the guy who just spoke? I'm sorry, I don't know your name. You've answered so many questions, but I don't know your name. Can you tell me your name, please?
I'm Muhammad Dahman.
Okay, thank you. Someone else, please unmute and try to attempt this. It's okay, I'll help you if you don't know. Don't worry. Anyone, come on. It's okay, you know, we'll help each other. I will help you solve it. Don't worry. All you have to do, okay, how about just someone unmute and read it, and we'll solve it together, okay? So just someone unmute and read it.
I think it's axillary.
Okay, do you want to read it?
A 26-year-old woman comes to the physician for a follow-up examination 1 week after undergoing rotator cuff repair surgery. Physical examination of the right shoulder shows decreased sensation to pinprick and light touch over the lateral shoulder. There is normal passive range of motion over the shoulder, but she has difficulty externally rotating and abducting her right arm. Which of the following structures was most likely injured during the surgery? Since there is difficulty externally rotating and abducting her right arm, I think that's deltoid, which is responsible for the abduction from 15 to 120 degrees. And
Okay.
lateral rotation is triceps, right?
Yes, perfect, excellent.
Both are innervated by the axillary nerve.
Excellent. No, triceps are innervated by the
Radial? I think it's radial, because a midshaft fracture, yeah, it's
yes,
radial.
and teres minor. Excellent. So two muscles that I spoke
Teres
about.
minor, yeah, that's the one I meant.
It's okay, no worries. So abduction, that is definitely by the deltoid, and the external rotation is done by the teres minor, someone correctly mentioned in the chat. So those are the muscles that are damaged here, right? And so what nerve supplies these two muscles?
Axillary.
Yeah, very good. So the axillary nerve is the one that is damaged. So good job. Both of you who answered and the ones who answered in the chat. All right, let's move on to the next question.
Can I ask you a question?
Yeah, perfect. Go ahead.
So I think when we damage, for an example, a nerve and there's a motor paralysis, in the like the place where the motor gets paralyzed, we lose skin sensation, right?
Yes.
So for an example, when we also lose the skin sensation, does the place where the muscle behind it also like get paralyzed, or like
Yeah.
they're not inclusive? So like
Yeah, exactly. So that's a good question. So if like let's say the example of deltoid. So axillary nerve not only supplies the deltoid in this case, but also the skin overlying the deltoid. So
yeah.
if the axillary nerve gets damaged, both the things would be damaged. Okay.
Okay.
However, there are other nerves that only supply either, because they give off like branches, different branches at different positions of the arm. So let's say one position they give off only motor branches, and then they go down the arm and it gives off branches to the skin, right? So in this case, motor would be damaged. Let's say damage to the motor nerve occurs, so the motor branch would be damaged, but the sensory would be intact. So that's not always the case. It's just in some nerves that is the case. You're correct.
Okay. That's what was my confusion.
Okay, perfect. All right, so I think we moved on. Yeah. So anyone read it. It's okay. We can answer it together. Anyone just read this question, aside from the people who've answered.
I can read it.
Okay, perfect. Go ahead.
A 61-year-old woman comes to the physician for a follow-up examination 1 week after undergoing right-sided radical mastectomy and axillary lymph node dissection for breast cancer. She says that she has been unable to comb her hair with her right hand since the surgery. Physical examination shows shoulder asymmetry. She is unable to abduct her right arm above 90 degrees. When she pushes against a wall, there is protrusion of the medial aspect of the right scapula. Injury to which of the following nerves is the most likely cause of this patient's condition?
Okay, so before you give me the answer, tell me the important things that like stand out in this question.
Okay, so it says that she's unable to, okay, yeah, comb her hair. That's, yeah, kind of, because it
Mhm.
shows that she can't abduct her arm. And then also shoulder
Exactly, she can't reach it
asymmetry.
above her head.
Yeah,
Yeah, perfect.
and she can't abduct her right arm above 90 degrees. And when she pushes against a wall, there is protrusion of the scapula, the medial aspect,
Do you know what this is called?
winging of the scapula,
Excellent, good job. And so what nerve in this case would be damaged?
long thoracic.
Very good, good job. So for those of you who were not able to reach this conclusion, let me tell you why. So first of all, very important concept in like almost every question talking about long thoracic nerve, they are going to mention a surgery that the patient underwent recently. Why? Because during surgery, especially mastectomy, where they remove the breast tissue, that could be because of anything. It could be because of cancer, or it could be cosmetic purposes, anything. When they remove the breast tissue in their surgery called mastectomy, the breast overlies the pectoralis major muscle. So one of the nerves that runs over the pectoralis major muscle is the long thoracic nerve. So during the surgery, if the surgeon is not careful, they can nick the long thoracic nerve. And once the long thoracic nerve is damaged, a muscle is paralyzed. Can anyone tell me what muscle is paralyzed if long thoracic nerve is damaged?
Serratus anterior.
Excellent, very good job. Serratus
Um,
anterior.
I have a question that it's kind of like there's a part it's just kind of confused me a little bit.
Okay,
So
wait, can I just finish my explanation, then I'll take your
yeah,
question. Yeah? Okay.
it's regarding this question, by the way.
Yeah. I'll finish explaining and then I'll answer your question. Okay?
Okay, sorry for cutting.
No worries, it's fine, no problem. Anyway, so the serratus anterior is damaged in this case. So serratus anterior, essentially what it does is that it acts like a glue between the scapula and the thoracic wall, the rib cage. So if the serratus anterior is damaged, then there is nothing holding the scapula against the thoracic wall. And so what happens is it's loose. And so when you ask the patient to push against the wall, you can actually see the scapula coming back like this. And I have an image in the next slide, so we'll get to it. And that's why the answer is long thoracic nerve. Yes, Abdurrahman, I can take your answer. I mean, question.
Okay, my name is actually Muhammad Dahman, but it's okay.
What?
My name is, I think you got mixed up. My name is Muhammad Dahman, not Abdurrahman.
I'm so sorry.
No, it's okay, it's all right. The thing is, it says she cannot abduct her right arm above 90 degrees. What really confused me is that I know that the trapezium, it's the one that abducts the arm above 90 degrees, right?
Yeah.
Or yeah, it does that. But like, isn't the trapezium gets supplied by the cervical nerves?
The cranial nerve, not cervical. Cranial nerve,
I
number
mean
11.
cranial nerves. So how is it colorated if it's the long thoracic nerve is being injured, not the cranial nerves?
Okay, you're correct. Trapezius does do it, but there's also another muscle, which is serratus anterior, that helps moving the arm above the 90-degree angle. And that is the serratus anterior muscle. So if the serratus anterior muscle is damaged, this can lead to impairment of abduction. Okay, she's unable to. It's not going to be completely limited, it's not going to be completely absent, but she's just going to have difficulty moving it above 90 degrees. Okay, so serratus anterior also, not only does it hold the medial border of the scapula against the chest wall, but it also helps with abduction. All right, so not always is it going to be trapezius. Trapezius, yes, if trapezius is damaged, again, serratus anterior would be covering, and trapezius does it above 120. She's talking about above 90. This question is saying above 90.
Okay.
You know what I mean?
So it's from 120 to 180. It's always trapezium.
Oh,
And
but
from
there's this portion 90 degrees and above which serratus anterior helps with, because it's basically the scapula. The serratus anterior lifts the scapula, and so your scapula is essentially responsible for moving your arm, abducting your arm from 90 to 120 alongside your deltoid. And so if that is damaged, then abduction would definitely be impaired above 90 degrees to 120. Okay. All right, next question. So this should be very easy. We just discussed it, so I want someone to answer it. Or you can just read it, doesn't matter. Come on, guys, anyone read it for me.
A 21-year-old woman comes to the physician for a follow-up examination. 4 months ago, she underwent posterior arthrodesis for thoracolumbar scoliosis. She has recovered well from the surgery, but noticed difficulties combing her hair with her right hand. A photograph of the patient's back is shown. The nerve that was most likely injured in the surgery originates from which of the following spinal roots?
Okay, so again, what nerve are we talking about here?
Long thoracic.
Excellent, good job. We're talking about the long thoracic nerve, and what are the indications in the sentence that led you to your answer?
It says that a photograph of the patient's back is shown, and in the photograph, you can see that there's winging of the scapula.
Perfect. So this is the medial region, and you can see that the medial region of the scapula is sort of protruding, which is pushing against the wall. No need to know like the surgery here, but again, just like a hint that she has undergone recent surgery. Okay. Also, one more thing, that she's unable to comb her hair. That's like a big indication. So she's unable to comb her hair. That is always usually part of the question with part of the question about long thoracic. So where does the long thoracic nerve originate from? What root values?
C5 to C7.
Excellent, good job. C5 to C7, very good. So I hope that it's clear. All the peripheral nerve injuries are clear before we move on to the bony injuries. Is everything good, you guys? Any questions you guys have? Okay, so everything is good. We can move on. All right, so the bony injuries are something so the reason why I did peripheral injuries before is so that when we move on to the bony injuries, it's going to be easier for you guys. So for the bony injuries or soft tissue injuries, they're usually occurring mostly because of some trauma or fracture, and that's essentially what we're going to discuss. So the first thing that we're going to discuss is the painful arc syndrome. So the painful arc syndrome, it's in the name. There is this particular movement or arc of movement that the patient does, and it brings them pain. Okay, so it's the painful arc syndrome is not necessarily caused by one muscle. So I know that there is a confusion with this, right? It's not just one muscle that causes it. It's when the rotator cuff tendons, they become inflamed or damaged, or they have inflammation, or they have like or anything that involves the rotator to them, it will lead to the inability of the movement of the arm. And in this case, this phenomenon is called the painful arc syndrome. So the one that is mentioned in your lecture is the supraspinatus tendonitis, the tendon of the supraspinatus muscle, right? So as you know, it's part of the rotator cuff, right? So anything that involves the rotator cuff tendons, if they become damaged, it leads to the painful arc syndrome. So what usually happens in painful arc syndrome, it usually occurs when there is an overuse of someone's shoulder, right? So can you think of like, tell me ways in which someone can use their shoulder a lot, and that would lead to like wear and tear.
Is it like overhead painting? I think
Exactly. So like painting, someone is a painter, right? And like the entire day they paint walls. Or a sportsman, basketball, volleyball, anything that involves them throwing like the ball over their head, moving their arms a lot, this can lead to rotator cuff tendonitis, right? And that can cause painful arch syndrome. Another thing is always consider in these like soft tissue injuries or like bony injuries, one of the causes is always old age, degenerating processes, because as a person gets older, their body also gets like their muscles and their structures inside get older as well, right? So over time, because they've been used a lot in their lifetime, they just start undergoing wear and tear. So every time in the exam, you don't know an answer to like these kind of questions, like what is the most common cause of like, let's say any bony injury or soft tissue injury, always consider overuse or degenerative process like old age or trauma. Like always like have them at the back of your mind, because these are like this will get you the mark. Okay, and obviously trauma. The question that this is painful arch syndrome, so that is your keyword. Overhead activities is something that would always be present in the question, and when that is there, think of painful arch syndrome. Another thing that they would mention is movement restriction depending on the muscle involved. So let's say it's like your supraspinatus muscle, so then definitely consider, okay, the patient would not be able to lift their arm, it's going to hurt them when they lift their arm. Okay, and another very common thing that you're going to notice in the question and nobody really talks about is the night exacerbation. So they're going to say, doctor, when I sleep at night, my shoulder really hurts, or like I can't sleep on this side of my arm. And so essentially you should consider, okay, painful arch syndrome, this patient has nighttime exacerbation. Okay. All right, so the MRI, any imaging, you guys, you're not required to know any imaging and how to identify in first year, because it's way beyond your scope. But because it was present in your lecture, I thought I should bring it. So if you see this is an MRI, you do it to identify any soft tissue injuries, okay? X-rays are always done to look at bones, and CT scan gives you also a very good view of the soft tissues, but in order to like see really well the soft tissues, your go-to imaging is MRI. Okay, so in MRI you can see that the muscle here is white, like this part, it's inflamed, this part. Okay, it's inflamed and it appears wider, that means it's undergoing inflammation, and this is what painful arch syndrome looks like in an MRI. All right, shoulder dislocation. So shoulder dislocation is something very common and honestly very easily fixed. You don't even need to, often people don't even come to the ER for this. They can just like fix it again, like by themselves, it's fine. So shoulder dislocation can occur in 3 directions. It can occur anteriorly, posteriorly, or inferiorly. Now I have said that anteriorly is the most common location for shoulder dislocation. Can anyone tell me why?
Because there isn't really ligaments, or like there is no muscles that are strong enough to support it. Meanwhile, we have, for an example, the rotator cuffs that are posteriorly there to prevent any dislocation, and we have ligaments that are strong. So these ligaments aren't like anteriorly there.
Excellent, very good job. Very well
But
said,
like,
right?
is it anti-inferiorly?
Yeah, so I was gonna come to that. It's anti-inferiorly, but it's anteriorly. Why is it anteriorly? Because if it's, you can't just say it's anterior, most like it's not entirely anterior. It goes anterior and then it comes out inferior because the ligaments pull onto it. Okay, so they bring it anterior. But you can't dislocate it inferiorly. You can only when someone is hit from their shoulder at the back and then their arm is pushed forward. But because of the ligaments present, the bone, the humerus is pulled downward. Okay, that's why it's called. And now, what is the most common mechanism? It's usually trauma, especially falling on outstretched hand. So I can't tell you enough, like how many times there's so many injuries in the upper limb that occur because of outstretched hand. Clavicular fracture, radial fracture, the fork deformity, which is a Colles fracture. the shoulder dislocation. There's so many things that occur because of, or like supracondylar fracture as well occurs because of falling on outstretched hand, okay? What are the predisposing factors? So if there is any loss of support, right? Now, what are the support systems in place to keep the shoulder together? There are several things that keep the shoulder intact. We have ligaments, we have muscles with their tendons, we have a lot of things. The shape of the bone also keeps it together. So rotator cuff muscles are one of the strongest muscles that hold your shoulder joint together. So any damage, any tear to rotator cuff muscles is going to predispose the patient to shoulder dislocation. Another thing is glenohumeral ligament. If that is damaged, that's one of the main supporters of the shoulder that can also lead to shoulder dislocation. Now, how would the patient come to you in the clinic? The patient is going to come with severe shoulder pain. They won't be able to move their shoulder. You will definitely see loss of contour of their shoulder. You will see that their shoulder does not have the same contour. It would look like something is missing. They'd be like a groove here, okay? And when you palpate their shoulder, like when you touch their shoulder, you will definitely feel like a dent at the tip of their shoulder. You will feel like there's something missing. Okay, and that's usually the head of the humerus is not in place with the glenoid cavity. And then the hand would be held in external rotation and slight abduction. So they do this to sort of keep the arm in place because they can't support their arm. And so this is the dislocation. So normally the head is supposed to be within the glenoid cavity, and so it would be displaced, it would be removed. This is also slight dislocation. What muscles pull the humerus anteriorly? Okay, who would like to answer that? Who can tell me what muscle?
The deltoid major, teres major, and latissimus dorsi.
Excellent, very good. So these are the muscles that hold it anteriorly, and so any definitely damage to these areas can lead to shoulder dislocation. All right. Frozen shoulder. Okay, so frozen shoulder is something that is again very common in athletes. Okay, so frozen shoulder, it's in the name that the shoulder is frozen, like they can't move the shoulder. And this occurs because of inflammation or fibrosis of the joint capsule. So the capsule is kind of like a tape that holds the head of the humerus within the glenoid cavity, that's the function of the capsule. It's like a glue, it's like a tape. It's a thin tissue. So the capsule is very, very tough. But when there's repeated movement, yes, we have the synovial fluid, but when there's repeated movement, especially in athletes, then it can lead to inflammation of this capsule, repeated friction. Once it gets inflamed, after inflammation, to resolve the inflammation comes fibrosis. So this capsule gets fibrosed, it gets harder, okay? And that leads to stiff shoulder. Now, what would happen? So what is the main cause? Like I said, it could be prolonged immobilization. So let's say someone, can you tell me, actually, how about you guys tell me, why would someone have prolonged immobilization? In what case would someone have prolonged immobilization? Can you think of anything?
Maybe they broke something and they have a cast on.
Yeah, very good, very smart. So, or can you think of something else?
He's a coma patient or he's very elderly and doesn't move much.
Very good, very good. So it's an elderly patient, bedridden patients, comatose. They have they can't. They don't move their arm for a long time because they have a cast on. Their capsule can become stiff. So remember one thing, when you move your shoulder a lot, the more you move your shoulder, the more, or any synovial joint, the more the synovial fluid is produced, because synovial fluid is produced from the synovium itself, the membrane itself. The synovial membrane produces the fluid. So the more you move a joint, the more fluid gets produced, okay? So when the person is immobile for a very long time, their shoulder tends to get stiff and it leads to frozen shoulder. any shoulder injury, like a fracture, like Shahad correctly mentioned, like it's a fracture, you put it in a cast, it can lead to immobilization. Diabetes mellitus can also lead to inflammation. Just remember, like diabetes, because they have diabetes is a chronic inflammatory process. They have less sugar in the more sugar in the body, less insulin. That can also lead to chronic infections and inflammation and stuff, and it can lead to frozen shoulder. It affects the non-dominant shoulder mainly, which is a very big clue into the reason why we get frozen shoulder, because the non-dominant shoulder, you won't use it as much, right? It's the dominant shoulder that you use a lot. So typically the patient is going to say, I have pain in my left shoulder, okay? And the pain is going to be dull, and it's not going to be sharp pain. It's not a shoulder dislocation. It's dull, always constantly there. And they will have severe restriction of movement. Okay, now let's move on to avascular necrosis of scaphoid. All right, so I want someone from the audience, like, why don't you guys tell me what is avascular necrosis of the scaphoid? I'm pretty sure Dr. Atif has mentioned this so many times.
Well, the scaphoid forms the floor of the anatomical snuff box where the radial artery forms. So if there's, usually this happens during a fall on outstretched hand, if there's a fracture of the proximal end of the scaphoid, the radial artery supplies that. So that could cause avascular necrosis because then there'd be no blood going through it.
Very good, excellent. So essentially the radial artery supplies the distal end of the scaphoid and not the proximal end. The proximal end is usually deprived of deprived of the blood supply. And so when you fracture it, right, when you fracture it and it splits like this, then the distal end is going to get the blood supply and the proximal end doesn't. And so this end undergoes avascular necrosis. And if it's left for very long periods of time, then the inflammation can spread to the bone, to other bones and the muscles and the tendons, okay? So what is a common cause? Prolonged immobilization, falling on outstretched hand, again, diabetes. Wait, I think there's a mistake here. Yeah, I think there's a mistake. I made an edit to the slide. It's actually, it should be something else over here. I'm so sorry. This is talking about the previous slides. So I apologize for the mistake. I'll correct it and I'll send it to you. But again, ignore what's written here. I'll just explain it verbally. So when someone falls on an outstretched hand, their scaphoid gets broken in half, and distally they get the blood supply, but proximal they don't have a blood supply. And as a cause, what would happen is that it undergoes necrosis, and then they can the infection can like spread to the tissues around. Okay, and what is the treatment? You usually just have to take the patient into the OR and physically surgically remove the bone. Next and last, I believe this is the last one. The last we have Colles fracture. So Colles fracture is actually a very distinct fracture, and it's because of this obvious deformity. So Colles fracture has this deformity. It's called the dinner fork deformity, and what that is that the patient falls again on an outstretched hand, and they break their bone, they break their radius, and as a result what happens is that it undergoes like different processes, and because of tendons and muscles that are attached in the hand, it pulls your radius up. Okay, when it pulls your radius up, the other bone goes down. So there is like this incongruency between the radius and the ulnar bone, and that leads to this obvious deformity. So there's a mistake in my slides. I'll correct it and I'll send it to you. This was supposed to be from the previous slide, so there's some sort of like problem here. But this part is correct. So what are the clinical features? The patient is going to have pain, obviously tenderness, just like any other trauma or fracture. They won't be able to move their wrist, and you can see this like angle, this angulated fracture. This is the Colles fracture or dinner fork deformity. Okay, I apologize for the mistakes, guys. I will correct my presentation and I'll share it with you. Can anyone solve this question? Would anyone like to solve this question? I think this is one of the...
19-year-old.
Yeah, go ahead.
Okay. A 19-year-old man is brought to the emergency department because of severe right shoulder pain and inability to move the shoulder after a fall while climbing outdoors. Examination shows the right upper extremity is externally rotated and slightly abducted. There is loss of normal rounded appearance of the shoulder. The right humeral head is palpated below the coracoid process. Sensation to pinprick over which of the following skin areas is most likely to be reduced.
Okay, so before you give me the answer, what does the patient have? How did you reach the diagnosis? And tell me like what led to your answer basically.
It's a shoulder dislocation
Perfect.
because it's a, I know there is, wait, I lost it.
Yeah, go ahead.
Yeah, shoulder pain. And he has no contour of the shoulder, I remember.
Yeah.
I can't read it, I know her.
Yeah,
Yeah,
normal.
appearance. Yeah, exactly.
And
And
also
right
your
humerus,
humerus is-
yes, it's palpated below the coracoid process.
Exactly. So in case of shoulder dislocation, I mentioned this, what nerve is very commonly damaged, especially in anterior shoulder dislocation?
The axillary nerve,
Very good, good job. And so if the axillary nerve is damaged, then what is the sensory supply of the axillary nerve?
is it the medial aspect of the upper arm?
No, so it's basically the deltoid, right? The deltoid region supplies the deltoid area, so the skin around the deltoid. So
Oh, yes.
again,
Yes,
what
thank you.
part of the what answer would it be then? If I'm telling you it
It's gonna
supplies,
be the, yeah, it's gonna be the lateral aspect of the shoulder.
yes, excellent. The lateral aspect of the shoulder. That is the one that is down. That is the one that is losing its sensory supply. Very good. B. Okay. Next question. Who would like to do this one? Anyone? Come on.
A previously healthy 25-year-old man comes to the emergency department because of a 1-hour history of wrist pain. He was playing football when he was tackled from behind and fell forward onto his outstretched right hand with his wrist extended. Examination shows a tender, soft tissue swelling of his right hand. Range of motion is limited by pain. An X-ray series of the right arm is shown. Which of the following is the most likely diagnosis?
Yeah. So first tell me the key words in this question. I want you to point out like the important parts of the question.
Fell forward onto his outstretched right hand with his wrist extended.
Yeah. And
Soft tissue swelling of his right hand.
and so what do you see in this image? Do you want me to explain it, or do you need help, or would you do it?
There's a fracture on the scaphoid.
Exactly. There's a fracture on the scaphoid here, right? Do you see this? Yeah. There's another thing. There's also one more thing in this X-ray that you can see.
Is there a fracture of the distal part of the radius?
Yes, excellent. Good job. So there is a fracture here. Not only is the fracture here, so I know that let me try annotating. Hold on. Yeah. Okay. So there is one fracture that is here. Okay. And then, wait. So then there's one fracture that is here. I'm going to point it. Oh. This is one fracture. Okay. And then there is also this fracture right here. Here, this is the fracture. Okay, so there are actually there are two bones that are being fractured. It's the distal radius of this part, and there's also the scaphoid bone that is being fractured here. So what kind of fracture we just talked about? Distal fracture of the radius. What fracture is this?
Colles fracture.
Yes, excellent. The dinner fork deformity. Okay, this is the dinner fork deformity. All right, let's move on to the next question. Oh, okay, that's it. So that was it for the upper limb. Now we have the lower limb. Lower limb is not that many, it's not that many slides, it's just a few slides. And then we will move on to I have a lot more questions in the lower limb. So what do you guys like? Would you guys like to take a break and then come back, or would you just want me to continue and finish it?
Can we, sorry, but can we start now and then when it adds Maghrib, we go pray and then we come complete?
Yeah, perfect. If that's what everyone wants, then sure, we can do that.
Can we just take a 5-minute break?
Sure, we'll take
Or
a
3.
Okay, so what we can do is that we'll take a break. I think Maghrib is at 5:10, right? Maghrib is at 5:10 these days. So we'll take a quick break and then 3 minutes, 2 minutes, not that long, and we'll come back and then we'll finish the lower limb and then I'll give you guys the day off. We can go right
Alright.
Maghrib.
Thank you.
Okay, so same rules apply for this lecture. You have any questions, you can stop immediately and sorry, just give me 1 second. Right, sorry for the interruption. Okay, so we are going to talk about the lower limb. And so we're going to talk about the nerve injuries and again, similarly, the bony injuries. So thankfully, right now, we don't have that many nerve injuries in the lower limb as per your lecture. We had more of the bony injury. So that's where my main focus is going to be. Again, if you have any questions, let me know and I'll try to answer it to the best of my abilities. Okay, so let's start with the superior gluteal nerve. So the superior gluteal nerve, does anyone know what muscles it supplies?
Gluteus maximus?
Yes, perfect. Gluteus maximus and also the medius muscle, okay? So the superior gluteal nerve comes from the fourth lumbar nerve to the first sacral nerve, so L4 to S1, and it also basically it's like a very, very big nerve. You see it, it's a very big nerve, comes after sciatica. Sciatica is the biggest nerve in the lower limb, and then comes the superior gluteal nerve. The most common causes of injury are iatrogenic. So iatrogenic means hospital related or caused by the hospital. So iatrogenic injuries are the ones that occur in the hospital. It could be iatrogenic infections, injuries, trauma. So when usually you give a patient an injection, typically younger patients, when you give them an injection in the Botox region, right? You inject in the upper medial gluteal region. So if you take the glute and you divide it into 4 quadrants, the upper medial one, that's where you're going to put the intramuscular injection. And sometimes, they may place it wrongfully or they may put it too deep, and that can lead to damage of the superior gluteal nerve. Okay, so usually the question stemmer is going to say that the patient came and then they had an intramuscular injection in their Botox, and that led to superior gluteal nerve damage or something. Okay, that is how you will reach the conclusion that this is severe gluteal nerve damage. There are no sensory supply of the superior gluteal nerve. It just mainly supplies the muscles, and particularly gluteus medius and gluteus maximus, and that would cause impaired hip abduction. The patient would have a positive Trendelenburg sign. Now, what is a positive Trendelenburg sign? So usually any injury relating to the hip region, right? It usually causes changes in gait, changes in the way a person walks. Okay, now particularly in Trendelenburg sign, what happens is that there is a pelvic drop. When a patient is walking, their pelvic is going to drop on the opposite side. Because the muscles are not contracting on one side, the other side is contracting, and they're going to pull the hip down, where the other side, the hip is going to go up. So for example, in this patient, you can see that the opposite side, this side is going down as he's walking, and the other side, which is the affected side, goes up. So healthy side, there's a drop in it. So the question would say, for example, he has a positive Trendelenburg sign, and he's tilting towards the right. So which of the following nerve would be damaged? And the option would say right superior gluteal nerve, left superior gluteal nerve, and like other options, select left gluteal nerve, always the opposite of the Trendelenburg sign. Okay. All right. Next, we're going to talk about the common fibular nerve. So the common fibular nerve comes from L4 to S2, and it basically it has a superficial peroneal nerve, like it gives off branches, right? Just like any other nerve. So it has a superficial peroneal nerve and it has a common peroneal nerve. By the way, fibular nerve is also called peroneal nerve, okay? Just to mention it, just to bring it up. So if there is damage to the superficial peroneal nerve, usually it's because of trauma. Again, I told you, every time we talk about nerve damage, always think of trauma or compression or stretching or something like that, okay? So this patient is usually going to come with stretch trauma, such as ankle sprains. They're going to twist their ankle, and that is going to pull on the it's going to pull on the superficial fibular nerve. They can also fracture the fibular head. So a question is going to show you an x-ray of a fractured fibular head, and they will be like, which of the following nerve is damaged? And so the answer would be common fibular nerve. Another way to damage the common fibular nerve is wearing something very tight. So people usually wear compression socks to prevent certain medical conditions. They usually wear very tight socks, or they wear like tight casts, or when you sit cross-legged for a very long time. All these ways you can damage the common fibular nerve. All right, now for the sensory deficit. So for the sensory supply, the fibular nerve supplies your shin region. And a very interesting way that you can test for common peroneal nerve, just like if you remember in the previous lecture, I told you for the radial nerve, to test it, you feel this region of the hand because it's supplied by the radial nerve, right? Similarly, going down to the foot, if you want to test for damage to the common peroneal nerve, touch the patient between the big toe and the second toe, right? This patch of skin is supplied by the fibular nerve. All right. Again, this, I'm not gonna like waste time and like talk about the text that's already on the slide. You can read it later. It's this part of the thigh that would, or sorry, the shin that would lose its sensation, as well as the leg. So almost the entire lateral leg is supplied by the fibular nerve. Okay, now let's move on to the muscular or soft tissue or bony injuries. So the first one that we're going to talk about is the foot drop. So foot drop, it comes from common fibular nerve damage. Okay, so it's the common one that's damaged, not the superficial one. And this leads to the flaccid paralysis of all the muscles in the anterior and lateral compartment of the of the leg. So all the muscles are in the anterior and lateral compartment are supplied by your common fibular nerve. And if that gets damaged, it results in this image, which is foot drop, this presentation.
Can I ask you a question?
Yeah, go ahead.
Isn't the lateral compartment of our leg gets supplied by the superficial fibular nerve? Oh yeah. I think I just got it now. If we're gonna damage our common fibular nerve, we're gonna damage our superficial. I just realized.
Don't worry, yes. So we're talking about damage to the common one, right? So just keep that in mind. It's supplied, the entire anterior and lateral compartment of the leg is supplied by the common fibular nerve. And so if that gets damaged, let's say in fibular head fracture, that can lead to damage to the nerve. And so what would the patient appear as? The patient is going to come with their foot plantar flexed. So remember, plantar flexion is when you point. Okay, so remember plantar flexion as plants grow on the ground, right? So the foot is pointing towards the plants, plantar flexion. And dorsiflexion is when it's pointing, the toes are pointing towards the sky, the opposite of plantar flexion. So the patient's foot would be extended, it looks limpy. When they walk, it's going to create like this slapping sound, and they would have like a weakness in ankle dorsiflexors or spasticity of the ankle plantar flexors. Okay, because spasticity occurs when a muscle is being contracted a lot, so that can occur. So as a compensatory mechanism, I just mentioned that people, in order to compensate and function normally, they change the way they walk, right? And there's going to be a change in their gait. So there are three gaits that you can commonly see in foot drop. There's something called the waddling gait, and for this, like, I want you to think of the way a penguin walks, okay? They waddle. So think of waddling gait. They lean onto the opposite side of the long limb. So because there's foot drop, the other limb is going to be longer than the other one. So they lean towards the long limb. Then there's going to be a swinging gait where they're going to move their foot like outwards. I'm going to show you some images right now. And then there's going to be steppage gait. So here's what it looks like. This is the waddling gait. Like I said, think of like a penguin that walks, right? So this looks like a waddling gait. And as you can see, this is the side that is affected. This foot is affected. That one is fine. And then this is the steppage gait. As you can see, they're bringing their foot out. They bring their foot around. Okay.
Is it waddling gait also caused by the gluteus minimus and medius?
Yeah, waddling gait is also caused by that. Okay, so we'll move on to some questions. All right, so anyone unmute, read.
A
It's
25
okay.
a 25-year-old, sorry, shall I do it?
Yeah, go ahead.
A 25-year-old man comes to the physician because of 3-week history of numbness in his left lower extremity. 1 month ago, he sustained a fracture of his neck on the left fibula during soccer practice that was treated with immobilization in plaster cast. Physical examination of the left lower extremity is most likely to show which of the following findings.
Yeah.
So he sustained a fracture in the neck of the left fibula that was treated with immobilization of plaster cast. I think it's so since he broke his fibula, that means the common fibular nerve is being damaged, which means that we cannot which it's gonna have like foot drop, the anterior compartment, the lateral compartment. So it's
excellent. So there's a drop.
It's impaired dorsiflexion of the foot.
Yeah, excellent. Very good. Good job. Impaired dorsiflexion of the foot, because the patient would have pronounced plantar flexion. They won't be able to dorsiflex their foot because they've damaged the muscles in the anterior
and they won't also to be able to avert it out.
Avert it, exactly. Excellent. They won't be able to avert it. In case of, like, let's say they ask you for the sensory supply, then, you know, the place between the big toe and the small toe, like the web, they won't be able to feel sensation over there. That is a good place to test for common fibular nerve damage.
Yeah.
Okay. Excellent. Great job. All right, next question. Anyone? Okay, Mohammed, do you want to try?
Okay. A 36-year-old woman comes to the physician because of a new onset limping. For the past 2 weeks, she had a tendency to trip over her left foot unless she lifts her left leg higher while walking. She had not had any trauma to the leg. She works as a flight attendant and wears compression stocking at work. Her her visual signs are within normal limits. Physical examination shows weakness of left foot dorsiflexion against minimal resistance. There is a reduced sensation to light touch over the dorsum of the left foot, including a web space between first and second digital. Even further evaluation is most likely to show which of the following. All right, so what we are trying to see is that she has weakness in left dorsiflexion, and
reduce sensation to light touch over dorsum of the left foot, including
left foot. It's between the so it's the common fibular nerve that it's being
perfect.
affected.
Perfect, very good. Now, when we want to further evaluate this patient, what do you think is going to be the problem? Like, what would be absent in this patient? Just give us-
Degrees. Wait, nor.
It could be present or absent, right? It's not saying, it's just asking us evaluation when you physically examine the patient, what would you see? So decreased ankle jerk reflex, would that be reduced? Ankle
No.
jerk reflex, no, right? Normal foot.
I think it's C.
Excellent, good job. It's normal foot inversion, right? Because normal foot eversion, you correctly mentioned, the person would not be able to evert their foot, okay?
Yes.
Patellar reflex has nothing to do with common peroneal nerve. Knee reflection, nothing to do with it. Hip flexion, nothing to do with it. Plantar flexion, nothing to do with it. Weak plantar flexion, weak plantar flexion. It's exactly the opposite of what happens. It's actually stronger plantar flexion, weaker dorsiflexion, right?
Mhm.
The answer is C. Excellent, great job. All right, anyone else for this question?
Can I try?
Yeah, of course, go ahead.
I have a question.
Oh yeah, someone asked to have a question, yeah. What is your question?
The TA told us that between the first and second fingers of the toes, basically the first and second web space, this is where you test for the deep fibular nerve. Is that the same as the common one?
No, it's the deep one, not the common one. Did I say the common one? I'm sorry if I did. My tongue must have slipped. I meant that's the place where the deep peroneal nerve. So the common one is at the top only, like on this side of the leg. And then as you remember, it bifurcates, right? It becomes superficial and deep. The only place that you can test for deep is between the first and the second toe, the web. Otherwise, this part of the foot, you'll sense or check for superficial peroneal nerve. I apologize if I made a mistake.
It's okay, thank you.
Okay, who wanted to attempt this question? It's
Yes,
actually,
me.
yeah, go ahead.
Okay, so a 70-year-old woman comes to the physician for a follow-up examination 2 months after undergoing a total hip replacement surgery. She reports that she has persistent difficulty in walking since the surgery despite regular physiotherapy. Examination of her gait shows sagging of the left pelvis when her right leg is weight-bearing. Which of the following nerves is most likely to have been injured in this patient?
Yeah.
So her gait shows sagging of the left pelvis. That means that the opposite side is damaged.
Exactly.
So the right and the gluteus medius and minimus are supplied by the superior gluteal nerve.
Excellent.
So the right superior gluteal nerve.
Very good. Excellent. Great job, guys. I'm so happy you're getting the AMBOX questions right. Because they're actually difficult, and so I'm really, really happy that you're getting them right. So someone said inferior gluteal. No, the inferior gluteal is not the one that gets damaged here. Inferior gluteal supplies the minimus, gluteal minimus. Gluteal maximus and medius is supplied by the superior gluteal nerve. And since this patient, I mentioned before that this patient is basically they're sagging towards the right side, which is which is basically the impaired side. And so they're sagging towards the right side, which is the normal side. And the opposite side is the affected one, which goes higher. Yeah. Maximus is supplied by inferior. Yeah, maximus is supplied by inferior. Wait, hold on. No.
Yes, I think you made a mistake. You said that the gluteus maximus and the medius are innervated by the superior. The maximus is by the inferior, and the medius and minimus are by the superior.
So what's written in my slides? Let me check. Hold on. Did I write it incorrectly?
I
Yeah,
wanted
it was
to correct
incorrect.
you. I was very confused
Me
because
too.
I remember.
Medius. Okay, so this is supposed to be minimus. Thank you for correcting it. I will change it and I will get back to you guys. So I'm going to repeat the concept again. The gluteus medius and minimus is supplied by the superior gluteal nerve, and the gluteus maximus is supplied by the inferior gluteal nerve. So thank you so much for correcting me. All right, so this was correct. Good job, whoever answered that. I think we have one more question related to the nerves before we move on to the injuries. Okay, yeah, this is the question that I mentioned while explaining. This is also easy. Anyone would like to volunteer? Anyone? Okay, I'll read it and then you guys can help me answer, okay? So there was this boy, he's
If you
5-year-old
don't
boy.
mind, I'll do it.
Okay, sure, go ahead.
It's I feel so annoying, but it's okay. A 5-year-old boy is brought to the physician because of an irregular gait 3 days after receiving age-appropriate vaccinations. Examinations of lower extremities shows no redness or swelling. When the child stands on his right leg, his left leg drops and his pelvis tilts towards the left. Sensation to light touch is normal in both legs. The patient's symptoms are most likely due to the injections of the vaccines into which of the following locations?
Yeah.
So I think it's inferior, so like it's in the inside.
Okay, so usually the vaccination, we basically divide the gluteus into 4 regions, okay?
Yes.
We have the superior lateral, superior medial, then we have the inferior lateral, then the inferior medial, okay? So commonly the vaccination is given in the superior medial region, right? Because that's the safest region. But
Isn't
sometimes
it outer, upper outer?
exactly the upper outer
So
quadrant.
it's
So which what would be the answer?
superlateral, it should be.
No. Superior medial quadrant is a quadrant that you give the vaccination in. So look, this is when they're saying superior medial, they mean medial of the body, not medial, like they mean medial of the body. Do you understand what I mean?
Oh, yeah.
Okay, lateral means lateral of the body. So upper outer quadrant is the one which is superior medial. Usually in the questions, they don't ask upper outer or lower inner. No, they usually ask they ask superior medial, superior lateral, or inferior medial, okay? So remember, we mentioned it here on the sides as well, that superior medial quadrant is the one where we usually give the vaccination. Okay?
So it's not superior medial. It should be either inferior or lateral or mid. So we can't.
Exactly. We can't give it laterally. Okay?
So it's inferior lateral quadrant of the right buttock, because the right buttock is basically paralyzed.
No, it's superior medial quadrant of the right buttock, not inferior lateral. Superior. Remember, you told me upper outer, right? So
Yeah.
upper superior, and when you said outer, you're using the word outer, but this question states the word medial.
Wait, is this question they're asking us why is this like paralyzed? Or
yeah, they're asking you why is the patient's symptoms are most likely due to the injection of vaccine into which of the following locations? They're saying that they inserted the injection in which location? The incorrect injection. Where did they insert it? They inserted it into the superior medial place. Do you get me? They inserted it too deep, where something like that, and that damaged the nerve, the superior gluteal nerve, because it runs in the superior quadrant of the buttocks. Okay.
But
I'm kind of confused.
The superior medial quadrant is the correct place to inject, right? It's just that they did it more deep.
Yeah, they just did it like wrongfully. Understood?
Okay.
So never inject in the inferior quadrants. Never. Because that is usually where there's, first of all, less fat. Second of all, it's their nerves running very close. You always inject in the upper quadrants. Okay. Now, preferably which one? It's usually superior medial or outer quadrant. So upper outer quadrant. But sometimes usually what happens is that they either go too deep, the patient does not have sufficient fat in the buttocks, so they're a very young child, and so they end up damaging this nerve. Usually the safest place is the deltoid. Okay?
Okay.
Is that clear, everyone? Okay, I have a question. So is the answer B or C? No. The answer is E, the superior medial. It's not C. I just said never inject in the inferior quadrants. The inferior quadrants are the ones that have the nerve supply and lesser fat. The fat is usually located at the top, the upper parts of the glutes. always inject in the upper parts, never in the lower parts. Okay?
So is the
I'm
superior
confused.
Okay, what's the
Because
confusion?
his nerve is damaged, right?
Yeah.
From the gait and stuff. Wouldn't that mean they injected it in the incorrect place, which is not superior medial?
No, that means, yeah, you're right. It could mean that, but that also could mean that they went too deep. That could also mean that. You're not supposed to put the syringe all the way inside. So they put the needle way too deep, and that could damage the nerve. Does
Oh,
that
okay.
So what is the right place to inject?
The right place to inject is on the upper quadrants of the buttocks, usually upper outer, okay? That is where you usually inject. Superior medial can be injected, but the correct one is superior laterally, or like just say superior, okay? The upper quadrants are the ones, because I think in your lecture, the word that he's used is upper outer. So I'm not going to confuse you with superior medial, superior lateral. I'm just going to say superior is where you inject normally, okay? Now, if you injected it and you injected it wrong, then usually what happens is that, especially if you injected it incorrectly in the superior medial quadrant, you can damage the superior gluteal nerve because it runs in the superior quadrant. And that can lead to the Trendelenburg gait. Okay? Exactly. Whoever said this, superior lateral to stay away from the sciatic nerve and superior gluteal to stay away. Exactly. So superior is always where you are going to inject. You're never going to inject it inferiorly. Is that clear, everyone?
No, because they didn't do it laterally, they did it medially. This is what happened.
This is what happened, exactly. So, and how can you know that it was how can you know that it was the superior gluteal nerve? Is because of the Trendelenburg sign.
Yeah.
Okay.
One last question. I'm really confused. Can you go back to the question?
This one, the
Yeah.
injection one.
Yeah, the injection one. So we chose the right buttock, but like I'm really confused. Like, why did we choose the right buttock? Like from here.
Okay, so let's go back to the side. Okay, when I talk about the Trendelenburg sign. All right, so what is a positive Trendelenburg sign? Positive Trendelenburg sign means that the Trendelenburg sign is present in the patient. Okay, now what is it? It is basically when the pelvis is dropping towards the opposite side of the injury. Okay, so in this question, the pelvis was dropping towards the left side because look, the muscles are contracting. They're pulling the buttocks down when the patient is walking. They're contracting the minimus and the medius. They're contracting, pulling it down. The other side, which the muscles are paralyzed, they're not contracting, they stay up. So the patient is naturally going to tilt towards the side that is healthy, right? The one that is. So in this patient, he was tilting towards the left side. So what is the
right side is paralyzed.
Yes.
Okay, makes so much more sense.
Okay. All right, now let's move on forward with the bony injury. So we're so the soft tissues and the bony injuries. We're halfway there, just a few more slides left. Okay, so in this, so now we're quickly going to review the ligaments. So the ligaments, there are a lot of ligaments, just like we have in the shoulder region. We have a lot of ligaments holding our hips together, right? The bones to the two bones. We have the iliofemoral ligament, we have the pubofemoral ligament, the ischiofemoral ligament, and then the very important one, the round ligament or the ligament of the head of the femur. So I got this really nice table from Ambos, and it talks about the every ligament and its function. So I personally wanted to make a similar table for you, but I found it very nice table on Ambos, and because of the sake of time, I'm sorry, I would have to skip it. But one thing that I want you to remember is the strongest ligament in the hip region, pelvic region, is your iliofemoral ligament. It's basically this ligament that's shaped as a Y, as you can see, and this is one of the strongest ligaments in the pelvic region, and it prevents the lateral rotation and hyperextension of the hip in the standing position. Okay, so this is the only one I really wanted to touch upon, and I wanted to explain this, but I'm sorry, because of short time, I won't be able to. Okay, now let's talk about dislocations. So dislocations are something that is confusing. It's actually confusing for some people because they confuse between the anterior and the posterior hip dislocation. Now, most of the time when you get a question, do not confuse yourself with anterior dislocation unless there are certain features in the patient's presentation, which I will talk about. Usually 90% of the cases of hip dislocation are posterior. Okay, very rarely would you see an anterior dislocation. 90% are posterior hip dislocation. And essentially what happens is usually, dislocation fracture occurs simultaneously. So what happens, what is the most common cause? It's usually dashboard injury. So I have a picture later on, and I'll show you what really happens. It's so the person is sitting, they're driving the car, and then there is like an impact and they go against the dashboard. So their femur is pushed back against the hip. It's actually very painful if you think about it. Like it pushed back, and that's how it pops out of the hip. So what does the presentation look like? Well, how would the patient come to you? They would be in severe pain. Their leg would be shortened because it's moving back, and it would be internally rotated. Adducted, internally rotated. Okay, this is what would differentiate between posterior dislocation and anterior dislocation. Anterior dislocation, it's internal rotation. Posterior dislocation is internal rotation. Anterior dislocation is external rotation. Okay. So this is what it looks like. As you can see that the head of the femur naturally lies here, and because of the dashboard injury, the force would be in the direction of the arrow. So the hip is pushed backwards this way, and it literally just comes out. Okay, so a very common complication of the dislocation, posterior dislocation, is sciatic nerve palsy. So sciatic nerve palsy is basically when the hip is dislocated posteriorly. It's going to cause an impairment in knee flexion and hip adduction, and it can lead to paralysis of the hamstring muscles and adductor magnets because they're essentially supplied by the sciatic nerve. And so the sciatic nerve, if you remember, it divides into the tibial nerve and the common peroneal nerve, and then the common peroneal divides into superficial and deep, right? So when it divides this way, everything below, like leg below, is going to be paralyzed. This is like the worst thing that can happen. It's like it's an orthopedic emergency, and you really need to take the patient into the surgery and fix and reduce the fracture. And causes of motor deficits would be, like, there are a lot. Like I can't list all of them, but you can imagine if sciatic is damaged, then how many muscles would be paralyzed. All right, anterior hip dislocation. So for anterior hip dislocation, this accounts to about 10% of the cases. So most commonly, this is not, usually going to be the answer. And one of the greatest, the most common thing that you're afraid of for all dislocation is avascular necrosis of the femoral head. So remember that the round ligament of, let me go back a few images over here. The round ligament of the femur is what holds the head of the femur into the acetabulum. So when there's a fracture or when there's a dislocation, this round ligament gets ruptured, and the round ligament carries the blood supply of the femur. And so when that happens, there's avascular necrosis of the head of the femur, very similar to what we spoke about in the scaphoid. And so usually what happens is that there is a direct blow from the posterior hip to the abducted leg. And so it's a very uncommon injury. Like, unless a person was walking on the street and they got hit from the behind, that's when you can think of anterior dislocation. Another thing is that they would have hip pain, which radiates to their knee. Their leg would be lengthened. So I know that in this image, the leg does not look lengthened, but the leg would be lengthened and externally rotated. This is a very, very, very important differentiating factor between anterior and posterior dislocation. And then very common complication is femoral nerve damage. Okay, for posterior, we said it was sciatic. For anterior, it's femoral nerve damage. And this is what it looks like. There's anterior dislocation. I know you can't really tell, and it must look very similar to the previous x-ray. Again, you guys, you're not responsible for x-rays. Like, do not stress on the x-rays, okay? You're not supposed to identify them unless if it's like a scaphoid fracture, that is important, or Colles fracture, that would be important. Otherwise, don't stress yourself out about it. Okay, now hip fractures. Hip fractures, very commonly fractured, are in elder people. So older people are more likely to fracture their hips. Younger people are more likely to fracture their shoulders, okay, because of like sport injuries and stuff. So usually femoral neck fracture are classified according to basically the location. They can happen within the capsule, so intracapsular, or outside the capsule. Intracapsular can involve the neck, the surgical neck, anatomical neck, and the head. And what usually happens is that older people, because they undergo osteoporosis, their bones are weak, they have decreased low bone density. As a result, their bones are they can easily be damaged. They're very, very, very weak. And so it can lead to that. Another way that you can fracture your femur is if there's metastasis. So usually when cancer spreads to the bones, it can spread to any bone, or the cancer can start from the femur and the bone itself becomes weak. So that can also lead to fracture. In young adults and children, think of like high-speed trauma, that could definitely fracture the femur. What about the clinical features? So how would the patient present? The patient will present with groin pain, shortened and externally rotated leg with toes pointing laterally, and with very minimal bruising. So one important thing, how can you differentiate this from hip dislocation, is the groin pain. The groin pain would not necessarily be seen in hip dislocation, but more commonly in femur neck fracture. Okay, lastly, I think this is the last one before we move on to the questions. Yes. So lastly, we're going to talk about the ankle sprain, something very common. And one of the very important things about ankle sprain is that you need to treat it as a fracture until proven otherwise. So ankle sprain, you treat it like a fracture. Once you get the diagnosis, the treatment is very similar to fracture. Don't need to worry about the treatment, but I'm trying to tell you that it's very important as well. Usually it involves the anterior talofibular ligament, and it again can occur in older people. You know, they have gait instability, they use walking sticks, they can slip, and ankle sprains are very common there. Also in young adults or children, sports or like high heels, they don't provide very good support to your ankles, and it can cause ankle instability, and as a result you can fall down. All right, so for what would the question usually talk about? The question is going to say that the patient has like obvious swelling. As you can see, they have hematoma. When you touch it, it's going to be really painful. However, when you do an x-ray to rule out fracture, it's not going to show any fractured bones, no broken bones, okay? MRI, you don't do it for every patient. It's a waste of resources. Just do an x-ray and say that, okay, this is not an ankle sprain. Move on. Not very important to know like treatment and like diagnosis, blah blah blah. Just right now, just know how to identify that this is an ankle sprain when you get it in a question. Okay, all right. So now we're going to talk about. So now we're going to quickly do the questions before you guys are free for the day from my end. Would anyone like to read this? Anyone? So we can quickly just finish.
I can solve it.
Yeah, go ahead.
Okay. A 25-year-old woman is brought to the emergency department after being involved in a rear end collision, in which she was restrained, and in which she was the restrained driver of the back car. On arrival, she is alert and active. She reports pain in both knees and severe pain over the right groin. Temperature is 37 degrees Celsius. Pulse is 116 per minute, respirations are 19 per minute, and blood pressure is 130/79. Physical examinations show tenderness over both kneecaps. The right groin is tender to palpation. The right leg is slightly shortened, flexed, adducted, and internally rotated. The remainder of the examination shows no abnormalities. Which of the following is the most likely diagnosis? So, I actually we can just focus on the slightly shortened, flexed, adducted, and internally rotated. That means it's posterior hip dislocation.
Perfect. Another clue that you can get is that it was a rear end collision. So what does that mean is that the patient was driving and they were hit from the back. So essentially the patient must have moved forward and hit the dashboard. And as a result, they had a dashboard injury where they get posterior hip dislocation. Okay. Let's move on to, yeah, so this is what the image looks like. They got hit from the back, then the dashboard came forward and pushed their knee backwards, and it caused posterior hip dislocation. Okay. All right, someone else for this one. Come on, anyone.
I'll do it.
Sure.
80-year-old a man is brought to the emergency room department by his daughter because of severe pain in his groin after a fall. 2 hours ago, he slept on a wet rug and fell on his right side. The doctor said he could not get up on his own and he can hardly walk. There was no trauma to the head or upper limbs. Medial history is remarkable for hypothyroidism. His medications.
Forget that. Go to the physical examination.
Physical examination shows a shortened right lower limb in external rotation. There are no visible bruises. Right of motion of the right hip is severely limited due to pain. An X-ray of pelvis is shown. Which of the following is most likely the diagnosis? I think it's the wait. I can't really see like the
X-ray. You can't see the X-ray?
I mean, I can see it, but like there is nothing we can see about it.
Okay, so let me help you. Okay, so first of all, let's pick out the clear indications from the question itself. Severe groin pain. Okay, after the fall, very important.
Yeah.
Forget everything else. No visible bruises, very important. Shortened right limb, right lower limb in external rotation.
External rotation. So it's probably a dislocation.
Wait, no, hold on.
Yeah, also a fraction can happen.
Okay, yeah. So let's go to the X-ray, right? So this is the X-ray, this is the leg, and this is the other leg. We're talking about the right, which is this one.
Yeah.
If you can see, it looks different from this one. I don't expect you to like know this for the exam or memorize this, but just if you look at it, it's different, right? This is what it normally.
Now I can tell there's a fracture.
There is a fracture here, and you can see that literally what has happened is that the head and the rest of the femur, it's literally moved. So the femur neck is actually completely gone, and this part of the femur has moved up, and the head is still stuck in the acetabulum. So this patient has femoral neck
fracture, but like it's not intracontric fracture because it's not at the head.
It's not at the head. No, exactly. It's not at the head. And how can you tell it's not at the head? Number one, the patient, you're going to see the patient, they'll probably say, and for the head, there's going to be absent femoral pulses, or the presentation is going to be very different. Aslan, he never talked about femoral head fracture. Like that's from the clinical lectures that I'm responsible for. I never really saw a femoral head fracture. Did he say femoral head fracture?
Yeah, we took it, and for an example, in the intercontric fracture, there is going to be an necrosis of the bone.
Exactly, avascular necrosis, right? So for this one, there won't be a vascular necrosis of the head per se because
there is no anastomosis that's affected by it.
Exactly, and the head is still inside the acetabulum, so the head has not been moved. How can you identify that this is a femoral neck fracture? Number one, he has pain in the groin and there's no visible bruising, so that is an indication that okay, this is femoral neck fracture. Okay.
Excuse me.
Yeah.
When would be the visible bruises?
Visible bruises, I'm pretty sure it would be in the intertrochanteric, sorry, not intertrochanteric, the femur head fracture, because that would definitely cut the blood supply and it would damage nerve, sorry, a vessel. Anytime there would be damage of the femoral artery, you would have bruising, loss of femoral artery pulses. But here, remember that for the neck fracture, there is no bruising and there is pain in the groin.
And
Okay.
what are the keywords of the intertrochanteric fracture?
Okay, I'm not sure about those because those were not part of my objectives, but I
okay.
can look at them and get back to you. Okay, I don't want to give you wrong information.
Okay, thank you so much.
No worries. I'll look at it and I'll get back to you and I'll like send you an email about how to differentiate between the two. Okay. All right, so that's it, guys. Thank you so much. And I'm sorry I took 25 minutes extra. If you have any questions, please email me. If you want me to repeat anything, please do so. My number and my email are written here. And I hope I helped you somewhat. And yeah, thank you so much for coming.
Thank you.
Thank you.
Thank you, Hiba.
Thank you.